Great to be here with Michael on another episode of Behind the Science. We're going to be talking about his and his team's recent work that's published in JACC titled Cardiac Screening for Conditions Associated with Sudden Cardiac Death, and their screening study of 104,000 patients. Michael, great to have you on.
Thank you very much for having me.
So I guess to get right into it, what do you think are the main takeaways from your guys' work from a clinical perspective?
Well, just to give a bit of background to your readers, sudden cardiac death in young individuals and cardiac disease in young individuals accounts for a significant proportion of morbidity and mortality. The issue usually comes to the forefront when an athletic individual, a competitive athlete, or someone who is well known gets affected. But the reality is that it affects young individuals who play sports in their everyday life. And some of the individuals are also affected when they're resting or even asleep. And essentially, there are studies out there that focus predominantly in athletic populations. And there are also studies that we have published, a couple that focus on the general population, but essentially look at the individuals who screen positive and they follow them up in terms of what was
Mm-hmm.
identified. So what we do with this study, which is based on the data that we acquire from the charity Cardiac Risk in the Young, which is the charitable organization that promotes cardiac screening in all young individuals, not just athletic individuals. We utilize the data and we managed to make a connection with national data sets as well in order to obtain outcomes. We focus on the general population, and this is the biggest cohort that has been reported in the literature of more than 104,000 young individuals, athletic and non-athletic, who underwent screening with a questionnaire, an ECG, and then they had a consultation with one of our cardiologists to go through the results. We connected their data with follow-up from national databases by emailing them directly, and people coming back to the charity if something had happened to them after the screening. And we managed to get follow-up in an impressive 98% of the total cohort. And the key message there is that 2.5% of the individuals screened, they had a positive screening. And out of the total population, about 1 in 300 will be identified with a condition that may predispose to malignant cardiac arrhythmias and sudden cardiac death. The other key message is that out of those individuals who were identified with a condition, 40% of them had an intervention, whether that was an ablation of an accessory pathway or an arrhythmia, whether it was implanting an ICD or a pacemaker, and we even had 2 cardiac transplants. So 40% had an intervention beyond lifestyle and medication. Now, the other side, which is very, very interesting and it's very novel in our study, is that of the individuals who screened negative, and it was the majority of them, almost 98%, after about 4 years of follow-up on average, a small proportion, but it is overall about 25% of the cohort of individuals who were identified with a condition. So 86 individuals were identified with a condition that may predispose to sudden cardiac arrest and sudden cardiac death. And this number also includes 29 individuals whose presentation was with a cardiac arrest or sudden cardiac death. So those people are people who were attending the screening, they were cleared, and then they came back and they were identified with a condition for lots of different reasons. Predominantly suspect, although I cannot be 100% certain because they presented with symptoms or, as I said, with a cardiac arrest. So the key message here is that 1 in every 40 individuals we screened had an abnormal screening. 1 in every 10 that we screened positive was identified with a condition, but still 1 in 1,200 that we cleared came back having a condition at a later stage. And as I said, there was a proportion of individuals who experienced sudden cardiac arrest and sudden cardiac death, and this goes to the second message of our paper, which we can discuss in more detail later in terms of the incidence of sudden cardiac arrest or sudden cardiac death, because there is a lot of variability in the literature out there, and some people claim that the incidence of sudden cardiac arrest, sudden cardiac death in young people is 1 in 200,000 or 1 in 300,000 person years. But our study after screening and after managing some of those individuals with conditions was closer to 1 in 18,000 person years. And a very important point here is that half of them were cardiac arrest. So if you do not account for the cardiac arrest in your total cohort, that means that you're probably missing about 50% of that group who experienced a sudden cardiac arrest, a sudden cardiac death.
Michael, I guess my question, you brought up a number of good points. My first question is around the sort of rare events that were deemed to be normal but then happened in the future, right? These were 86 patients. They had not abnormal results on the screening and then later developed a SCD associated condition. And I wonder how you think about trying to detect these events in a screening study and what other pieces of information you would like to have and how you might implement a screening protocol to catch these cases.
That's an excellent question and a challenge that we constantly face. So, I mean, the first thing to mention is that based on our study, we were able to detect 75% of the conditions that eventually were identified. For the 25% that we're missing, I think it's important to state that we need to be pragmatic in terms of what screening can do and what it cannot do. And I have no doubt that we will not be able to get to a point that we're able to detect all the conditions that predispose to cardiac arrest and sudden cardiac death, at least with the tools that we usually currently use. For example, if you look at coronary artery anomalies, it's very well established that people are usually free of any symptoms. They don't have a family history because it's a congenital condition, and the ECG is bound to be normal in those individuals. And that's why it's very, very important to state that screening is only one part of cardiovascular disease prevention, sudden cardiac arrest prevention in young people, with emergency response planning, with quick CPR and effective AED use being the other part. And we know that effective AED use can potentially revive up to 100% of individuals. The only issue, of course, there is that it has to be someone in a public arena, and we only have about 10 minutes to intervene. The other thing about the conditions is that they can show age-related penetrance. For example, it is well established that cardiomyopathy, such as hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, but even ion channelopathy, such as Brugada syndrome, may present at a later age. And here comes the issue of repeat screenings. And our model was limited in terms of we offered only one-off screening to all those individuals. And as you realize, someone may get screened at the age of 15 or 16, and then something may happen at the age of 20, 25, or 30. And there is a big gap there that it can be a condition that developed, it can be a condition that happened during the life. Myocarditis could be a good example. And we're uncertain as to what was the exact cause. And we've got some clues from our data that suggest that repeat screening may be beneficial, in that there was on average a 4-year interval between a negative screen and the diagnosis of a condition, or presenting with sudden cardiac arrest or sudden cardiac death. And also, if you look at the group of cardiomyopathies, then we can see that the cardiomyopathies that were detected by our screening were 4 years older compared to the cardiomyopathies that were missed by our screening. There is also some good data from other colleagues and groups around the world, and particularly the group in Padova, which has demonstrated that with repeat screenings, they could increase the diagnostic yield of their screening program by about 60%. So I have no doubt that repeat screening will be beneficial. The problem, of course, becomes the available resources, particularly in the context that we perform the screening in the United Kingdom.
Yeah, and to piggyback on that point, right? I think it would be great if we could offer serial screenings to people, and it might be able to detect a number of these conditions. Then the question becomes, how do we make this deployable at scale, right? Because this is ideally for all young people, right? And I wonder how you think about that, and how you might think about using AI maybe to sort of help manage the resources. I'd love to hear the thoughts about that.
Yes, so this is a question we're constantly pondering about, given the limited resources within our screening program. To give our readers some perspective, there is no national screening program in the United Kingdom. So there are some sporting organizations, whether it's football or rugby or cricket, that screen their elite athletes, mostly not the grassroots athletes, aside from the Football Association. And essentially, the charity Cardiac Risk in the Young is a relatively small charity that has been advocating for screening and is trying to perform a national screening program, essentially. Uh, However, that comes with limitations in terms of the available resources. And we do have a long waiting list of individuals who want to get screened. So repeat screening at this point presents a challenge. So what we're trying to do is to use technology to our advantage. And there is no doubt that there have been many advances in terms of technology. And what we're trying to do is to optimize our screening program and reduce costs, as well as bring down the barriers regarding the availability of expertise. Because, as you know, it can be challenging even for the most experts of cardiologists to interpret the ECG of a young and athletic individual if they're not used to it. So the two things we're working on is potentially to automate the questionnaire, which can be a challenge again for the most experienced of physicians to judge, for example, whether a chest pain is a malignant symptom that requires further investigation or simply something that can be dismissed. And also, if you take that in the context of the screening program that we run, that you potentially have a few minutes to converse with every individual rather than a clinic consultation that you may have full 20 to 30 minutes, that can be an extra challenge. So we're working on a point-based system, and hopefully we'll publish something on that very, very soon in terms of the questionnaire. And in terms of the ECG, again, we try to automate the interpretation of the ECG based on the traditional criteria that we use as cardiologists for young and athletic individuals. And there are certain models, certain companies out there already, both in the US and Europe, that offer that. There are very, very few, but there are a few there. And the other thing I think which is important is obviously given that the advanced ECG analysis and artificial intelligence is progressing, and given the fact that we've got reasonable evidence that it can detect conditions such as hypertrophic cardiomyopathy, long QT syndrome, or even the risk of malignant arrhythmias and sudden cardiac death has been tested in older population, I think that there is a great prospect for ECG-related screening, and I suspect that the utility of a simple test such as the ECG may further advance in the future and offer us a greater opportunity to improve and expand our screening program.
And you pointed something out that I want to just harp on for a second, which is that when you look at younger patients, right, younger people, there's a lot of heterogeneity in the EKG, right? Because just human to human variation, and most people are going to be not having these conditions associated with SCD, and it takes a different lens to interpret that EKG. So I wonder if you think about having specific AI models that aren't trained on the whole corpus of pathologic conditions, but maybe just on healthy patients and patients or just on young people, and then young people for whom some of them have SCA, SCD, so sort of a focused AI model versus the traditional AI EKG models that are trained on, all sorts of things, aortic stenosis and into heart failure and all these other things, right? So I wonder how you think about that trade-off, given the point you mentioned about EKG variability.
My personal view is that it is very, very important for whatever models that we develop that they are trained in the population they're supposed to serve. Um, I think, particularly in sports cardiology, we've made the mistake before of taking models that were developed in disease populations and thinking that if we put them in low risk populations, they will perform equally well. Uh, there are many studies around I can quote of trying to differentiate, for example, severe hypertrophic cardiomyopathy from athletic adaptation to exercise.
Yep.
And they were using severe phenotypes of hypertrophic cardiomyopathy with healthy athletes with no hypertrophy. And obviously, every index was coming as wonderful in terms of sensitivity and specificity of identifying the condition. But then we realized that if we take a very mild phenotype of hypertrophic cardiomyopathy with a healthy athlete with left ventricular hypertrophy, they don't perform that well. So I think it's important that whatever models exist out there that come either from older populations or from disease population, that they're tested in a population like ours, which is essentially a high number of low-risk individuals, of whom a small proportion will develop particular conditions of cardiac arrest, sudden cardiac death, and validate those models or potentially modify those models so they're able to serve that particular population. And that's the next step. That's what we're working on. So the work that we've done to produce this paper that is published in JACC will serve as the basis for us to expand our population. And now we're up to almost 300,000 young individuals where we've got their XML ECG files. And we have established now a process that we're continuously able to go back to those individuals directly, but through also national data sets in order to constantly update those outcomes. And that will allow us to potentially train, given the numbers that we've got available, such models for this particular population and with this particular purpose. I have to say I'm very, very optimistic about what technology and AI can offer in this particular setting.
Absolutely. I hope that it can offer something, and certainly from all accounts, it sounds very reasonable. I think one thing that you guys wrote at the kind of last line in your paper was you kind of talked about the cost of the program, right? Over the time period that you guys had sort of adjudicated these outcomes for, and you write, $97 or 97 pounds per person screened, 17,000 per detected cardiac condition, and 29,000 per detected cardiac condition associated with SCD. So if I just take, and I guess I want to sort of talk about this because that might be the point that people feel is the most relevant, because cost is going to be the sort of big barrier to expanding this, right? And let's just take 30,000 and let's assume that's US dollars for just 1 second here, because let's assume 30,000 US dollars per detected cardiac condition is what the cost of the screening program is. And I just, quick search, but the patients in the US who survive 30 days post cardiac arrest, the average cost apparently is about, let's just say about $39,000 to $130,000. Okay, that's just the cost of the hospital admission, assuming that they live for 30 days. And I wonder, in some sense, that's much, that's much higher than what you guys are reporting, right? So it sounds like this program, because it could actually be cost effective, but I just want to know if I'm thinking about that correctly. And my second point is that 30,000 number that you guys quote, is that including the ICD implantation cost, or is that just the cost of screening?
So the first thing to note is that for this particular paper, we did not perform a cost analysis. What we quote in our discussion is for a smaller paper of about 30,000 individuals that we've published before. And the costs are exactly as you describe them. And with those costs, we try to calculate the screening program, the further investigations, and the management of people that we knew of, essentially. Okay, so there are obviously some flaws in those calculations. However, I think we always need to take it into context, because I hear people saying, for example, that €100 that we quoted there is a bit too much per individual. But we always have to take into the context of what we spend in general for healthcare. And as you said,
Right.
an individual, for example, who has a cardiac arrest costs to the system a lot of money in terms of treating them, in terms of surviving with or without neurological disability, so on and so forth. And the other thing is that I think we always need to have a bit of perspective, because I can tell you that in the United Kingdom and in the United States, we spend a lot of money in procedures as well, whether that's ICDs in people in advanced stage, whether those AF ablations, whether that's opening a chronic total occlusion, so on and so forth, where the evidence varies and it may not be that strong, but we have decided that it's worth taking that cost. So I think it's a bit like the argument we've got generally for cardiovascular disease prevention in the older individuals. Let's think of atherosclerosis, right? So I try to put it in a similar perspective for the young individuals. Yes, there will be a cost. Yes, we need to try and reduce that cost as much as possible. And I'm optimistic that with the technologies that are developing, we will be able to do so. But as a society, we will have to decide what that line is and how acceptable that cost is to us, accounting obviously for the fact that it's very difficult to calculate of the years of life lost potentially and the productivity, which is not on an 80-year-old, it's on an 18-year-old who has potentially another 60, 70 years to offer.
Yeah, I think this program is based on prevention, right? It's based on trying to prevent and delay the progression of these conditions that individuals may have, which is a shift in terms of how current insurance models think and work, right? I mean, we don't do, gene therapy as an example, or even colonoscopies, right? There is a huge process to getting that approved as a preventative treatment, but it's encouraging because now across all these fields we have starting to develop more of a preventative mindset, and this paper and this approach is one example of that in cardiology. So it's such an exciting time, right? For me at least, to kind of be involved with the preventative space. And I think my last question to you is, where do you see the most excitement in terms of future steps? And maybe that's AI, and we already talked about it, but just wanted to kind of give you some space to kind of give us thoughts on what you're thinking about in the future.
In terms of this particular field and the conditions that cause issues and potentially sudden cardiac arrest in the young individuals, I think in the field of screening, AI is a very exciting prospect, and it's a very exciting prospect because it can potentially help us bring barriers down, and there are significant barriers in terms of cost, in terms of resources, in terms of expertise, and potentially help us identify more of those conditions and get that sensitivity from 75 potentially to 80 and 90%. But there are other aspects as well, because obviously one of the issues that we've got is that we're not looking for one condition. We're looking for multiple conditions. We're looking for potentially genetic conditions. So I think there is great prospect in terms of the combination as well of genomics and artificial intelligence that are developing very, very quickly and may provide us with new therapies, may provide us with new intervention, new ways of identifying individuals at an earlier stage. Because for me, screening, it's not about disqualifying anyone from sport. It's not about taking freedoms away from people. It's about people having the information to make their own decision with the assistance of the doctor in terms of their future, whether that's career, whether it's sports, whether it's a family, so on and so forth.
Awesome. Thank you, Michael, for being with us today.
Thank you very much for having me.